Welcome, everyone. Thank you for joining us for today's Cardiogenetics webinar. My name is Dr. Casey Gifford, and I'm a member of the Betty Irene Moore Children's Heart Center at Lucile Packard Children's Hospital, Stanford, and an assistant professor of pediatrics at Stanford School of Medicine. Our main goal at Lucile Packard Children's Hospital is to ensure that your children thrive. And this mission we live and breathe in everything that we do, including in our researching, diagnosing, and treating of genetic cardiovascular disease, which is the topic for today's discussion. Two of our genetic counselors will join me to share their knowledge on how the DNA in all of your cells can shape your health, including the ability of your heart to function properly. This is the first event in a three-part Facebook Live series, where the goal is to cover different topics related to the research and care of those diagnosed with cardiovascular disease. Just a little housekeeping before we get started. We'll have a Q&A at the session at the end, so please post any questions that you have in the comment box. Now, without further ado, we will turn the time over to our panelists. Ladies, please go ahead and introduce yourselves.
Thank you, Dr. Gifford. My name is Aiste Narkevichut, and I'm a genetic counselor working at Lucile Packard Children's Hospital, Stanford. I work in the cardiovascular connective tissue disorders clinic, and we see individuals with issues that affect the aorta, which is the main artery that comes off the heart and brings blood to the rest of the body.
Great. And my name is Hannah Eisen. I am also a cardiovascular genetic counselor practicing in both the adult and pediatric hospitals. I see many different types of genetic heart conditions, but primarily specialize in meeting with patients and families with inherited cholesterol problems and congenital heart disease, isolated congenital heart disease. And with that, I think we'll go ahead and pass it on to Aiste to get us started with this discussion.
Thank you so much. So today we'll take a look at basic genetics principles. So we'll talk about the big picture. How do genes affect the heart? We'll talk about, well, what types of genetic heart conditions are there and how genetic testing can be helpful to help identify what the kind of genetic basis is and how to best care for that patient. And then we'll also see when it might be helpful to consider a genetic counseling visit and what to expect during that visit. So let's jump in. Starting with the very big picture, the human body is made of smaller units called cells. And if you take a cell and if you open it up, inside you will find these structures called chromosomes. Chromosomes carry genes, which are the information that tells our body how to grow, how to develop, how to function properly. And genes are made out of DNA, which is essentially a very long string of letters. So, as I mentioned, we have chromosomes, and typically we all have 46 chromosomes. The first 22 pairs are the same between males and females, or women and men, boys and girls. And then the last pair determine the sex of the individual. So two X chromosomes make the individual female, and then an X and a Y chromosome, as shown here, make that individual male. One condition that can affect the heart that you may have heard of that is caused by an extra copy of chromosome 21 is Down syndrome, but there are other genetic conditions that can cause differences in the number of chromosomes that can also affect the heart. So when we think about, well, why are genes important? We know that information in that DNA letter code is used by the cell to make a protein. And that protein is important in providing the structure of the heart, in making sure that the heart's electrical activity works properly, making sure that the veins and the arteries that connect to the heart are as they should be. So they're really these proteins, you can think of them as workers that make the heart function properly. And we know that sometimes an individual is born with a difference in that DNA letter code in a particular gene. So, and that can really impact the protein and therefore impact the heart. So at the kind of at the top part of the slide, what I'm trying to show is when one of the DNA letters is changed here, a DNA letter is changed from an A to a T, that can lead a difference in one of the components that are used to make the protein. The protein then might have a different structure and might work differently in the heart, and that can make the heart work differently. Similarly, a difference in that DNA letter code can actually lead to that protein not being made altogether. And that can also have important consequences in how the heart works.
So we wanted to move into talking more about different genetic heart conditions, but before we do, we want to talk a little bit about heart development, the different components of the heart and how they're important for heart function, because I think that will lay a nice foundation when moving into talking about different genetic heart conditions. So as Aiste mentioned, our DNA carries genes, and we think there's close to 20,000 of them. And as Aiste mentioned, we can sort of think of genes as workers of our body. Each gene has a very specific job that it goes out and performs once it's created. And we think that there's close to 500 different genes or so that are involved in heart formation. And I kind of like to think of heart formation like building a house. When you think about what it takes to build a house, you need many different workers, all with sort of different specialties working together to make sure that the house gets built correctly and that it has a stable structure. It's very similar thinking about heart development. We have many different genes or workers that have to work together and do their job properly in order for the heart structure to be formed the way that it's supposed to. And the heart structure is really important for the heart function. So some of the different components of the heart that are important for its function are the chambers of the heart. We have two upper chambers called the atrium and two lower chambers called the ventricles, which are important for helping with oxygenating blood and making sure it gets to the right part in the body. We also have sort of the plumbing of the heart, which are these larger vessels that leave the heart and help with oxygenating blood and also allowing blood to go from the heart to the rest of the body through the aorta, which is the red vessel shown here. So the overall structure of the heart is really important for its overall function. And then some of the other components that are really important for its function is the actual heart muscle itself. So that heart muscle has to work correctly so that it's able to squeeze properly and squeeze blood from the ventricles out to the body. And then there's also, like Aiste had alluded to before, an electrical system of the heart that actually moves through the heart muscle and it allows the heart muscle to contract, helping again with that squeezing mechanism that allows allows blood to leave the heart and go to the body. And so thinking about different genetic heart conditions, there are different conditions that can actually affect those different components of the heart and make it so that part of the heart is unable to work correctly. And that can be due to specific genes or workers not doing the job that they're supposed to do. So we're going to talk a little bit about some of those genetic heart conditions. So one of the more common genetic heart conditions are something called a cardiomyopathy. And this is a condition where somebody has either a thickening of the heart muscle or a thinning of the heart muscle that makes it so that the heart muscle is not able to squeeze the way that it's supposed to allow the blood to leave the heart to go to the rest of the body. There are some genetic heart conditions that actually impact the vessel that we talked about previously, the aorta, and impacts the integrity of the aorta, which can cause it to bulge or be at risk for basically rupture and can cause significant health complications. There are also single genetic causes of congenital heart disease. So we know that there are some people that are born with congenital heart disease because one specific gene or worker that was really important for heart development was not doing its job correctly during that time, and therefore caused the heart to not form and have that structure that we just went over the way that it is supposed to. And sometimes some of those single genetic changes can cause just a difference in how the heart is formed and only the heart is affected. But there are also some times where some of these genetic changes not only impact heart structure, but also can impact other parts of the body and different organ formation. There are other genetic heart conditions that can cause difficulties with the electrical signal, where the electrical signal is not able to get through the heart muscle the way it's supposed to, and therefore the heart muscle is not able to contract the right way. And there are other genetic heart conditions that can cause really high cholesterol starting from a young age and can cause really early onset heart problems and heart disease. And so at Lucile Packard Children's Hospital, Stanford, and at the Betty Irene Moore Heart Center, we have many different team members and teams here that really care for and evaluate patients that we suspect have these genetic heart conditions and assist with management, genetic testing, making sure other family members get screened, all of that. So really dedicated teams here at Lucile Packard Children's Hospital. And you probably heard me just say, you know, we treat patients and their families. And the reason why I say the families component too is because a lot of these genetic conditions are inherited, meaning that there's something that are passed through multiple generations in a family. And so when we identify one individual in the family that has a genetic heart problem, we know oftentimes there are other family members that also are at risk for developing or having a genetic heart problem. And oftentimes these can be inherited from our parents and then passed on to our children. But I also want to note that there are some genetic heart problems where only the change that's identified, the genetic change that's identified is brand new in that individual, where it's not something that was necessarily inherited from a parent. And so knowing that can also be helpful for us in determining, you know, what the risk is to future children and what the risk is for that child to have a future child with one of these heart conditions. So we want to move into talking a little bit more about why genetic testing for genetic heart conditions is important. Oh, you're muted, Aiste.
Oh, thank you. And to do that, it's helpful to learn a little bit more about, well, what types of genetic tests exist. So there's no one broadly used clinical genetic test that can detect all types of genetic changes that can affect the structure and function of the heart. So we as genetic counselors work closely with cardiologists. We work closely with other specialists to help determine the best test to use to uncover that underlying genetic difference that is causing the heart to work differently. So one of the tests that looks for extra or missing copies of the chromosome is shown here. That is the karyotype. It's essentially a picture of the chromosomes. And with that, we can tell if they're missing or extra chromosomes. And we can also tell if there are any large pieces of the chromosome that might be missing or that might be extra. There is another test that is sometimes used called FISH, which stands for fluorescent in situ hybridization. This is a test that is a little bit similar to the karyotype in that it looks at the chromosomes, and basically what it does is it allows a fluorescent probe to attach to a certain part of the chromosome, and if there's a part of the chromosome that might be missing or that might be extra, that shows up as a different number of fluorescent signals when you do the test. This test is best designed to look for just one of the 46 chromosomes, or sorry, one copy of the 23 copies of chromosomes that we have. Similar to FISH, which looks for missing or extra copies, we have the microarray. It also looks for differences in kind of the copy number of the chromosomes. And it looks across all 46 of them because it uses a different methodology. So it's a good broad test to look for small differences in kind of the chromosomes to see if there are more or if there are more copies or fewer copies than typical. And then finally, we have a test that is the sequencing test. This is one of the most commonly used types of tests in genetic testing for heart conditions, which reads the DNA letter code letter by letter, and it looks for little differences. So you can think of them as spelling errors, where a letter might be changed into another letter, or maybe a few letters are removed, or a few letters might be added. And we can test one or multiple genes with this test. We can also look at certain areas of all of those 20,000 genes that we carry. And we can also do an even bigger test in which we look at all of the genetic information that we can actually read or sequence. Just as an interesting tidbit of information, Stanford recently won the world record for the fastest genome, so the fastest read of all of the genetic information and interpretation of that information. And we're hoping to get that record to an even better, faster time in the future.
Great. So, like I just mentioned, there's many different types of genetic tests. And, as she mentioned, we work really closely with our team to determine what test is going to be best for our patient. So really choosing a test that we think is most likely to identify the specific genetic cause of somebody's genetic heart condition. And so genetic testing has really come a long way over the last few years. And the process has actually become a lot more simple and I think less cumbersome for our patients. So for example, instead of needing a blood sample for every test, there's actually oftentimes a saliva sample option. So oftentimes Aisha and I can place an order at the lab and ask the lab to send up our patients a saliva kit in the mail, where we just take a little bit of saliva and there's no pokes or traveling to clinic. So that's really great. The cost can really vary based on the type of test that is selected, but oftentimes, especially with many of the panels that we use, the cost can be around $250 or less. Depending on the test that's chosen, results take anywhere between 4 to 12 weeks. So those kind of smaller panels, usually the turnaround time is around 4 weeks, sometimes sooner. For some of those larger tests that have to look at lots of different genetic material, that can take a little bit longer because of that analysis process as well, really needing to sift through a lot more data. And then the great thing about a lot of the labs that we use these days is that if there is a genetic change identified, that many of these labs offer free genetic testing to at-risk family members, which is great and allows us to more easily identify who else in the family might be at risk for also having a genetic heart condition and should have their heart looked at more closely throughout their life. So we're going to move into talking now about what we might find when we do genetic testing. It's not always black and white, and so we're going to talk about some of the nuances. So one of the results that we can find is that it does come back positive. And that means that we found a genetic change that we feel pretty certain is the cause of an individual's heart condition. And we feel that we can make that call because of lots of different data that's been collected from lots of other patients and research to better understand how that genetic change might actually cause that heart disease. And I will talk about this in a little bit in just a few slides, but it's also very helpful for helping to identify who else in the family could be at risk. It's also possible that genetic testing comes back negative. And this certainly happens even in patients where we have a high level of suspicion that there's a genetic condition at play. And this does not mean that the cause of the heart condition isn't genetic. It just means that maybe, our knowledge of all of the different genes that are associated with that heart condition is not yet complete. And so we don't yet know to look for those genes when we're doing genetic testing. And we know there's just other limitations to genetic testing technology. But certainly, we're moving more into a realm where we're learning more and more every day. And then lastly, the third possible outcome sort of sits in the middle of those two, and it's called a variant of uncertain significance. And I will say that these are also very common for us to have within our patient population. So a variant of uncertain significance essentially means that there is a genetic change that's identified, but we don't have enough information on it to know whether or not it's associated with someone's heart disease, or if it's just a normal genetic change that is benign and just contributes to diversity. And so these can be sort of tricky. Like I was saying before, in order for us to say that a genetic change is positive, we really want to feel like we have a lot of concrete data that allows us to make that call. And with variants of uncertain significance, we're not quite there with being able to make that call. And so this is also really where things like research come into play and can be really important and helpful for sort of pushing us forward in terms of our knowledge of how these different genetic changes cause heart conditions. And so Dr. Gifford's actually going to talk a little bit more about these efforts in one of the future series that's coming up. But there is a lot of exciting movement here at Stanford to really make efforts for us to better understand the genetics of heart conditions so that we can continue to help our patients and just sort of be on the forefront of care. And so moving into talking a little bit about, let's say we see a patient with a suspected inherited cardiomyopathy and the result comes back positive. Why is that information really helpful for us to have? What can we do with that information? So, sometimes cardiomyopathy, I'm using this as an example, can be caused by something unrelated to genetics, some sort of environmental factor or something that we can't quite put our finger on. And so knowing whether or not somebody has a primary genetic cardiomyopathy can be really helpful in sort of clarifying what we're expecting the trajectory of that person's care to look like. It can also help us with prognosis. So is that child potentially going to need certain types of heart medications? Might they be at higher risk for needing a heart transplant in the future? Are they at risk for certain heart rhythm problems? And then that can also inform our medical management. Is there other imaging that should be performed? Does a patient need, in the instance of a cardiomyopathy, something like a pacemaker or an ICD, which is a device that can help the heart rhythm continue? So is that something that's going to be needed for that patient's care, or should other specialists be involved? So having a specific genetic change that we've identified as the cause of someone's genetic heart condition can really, again, help kind of clarify what's going on and help set a plan for treatment of that patient. And then secondly, it can really help with family screening, which is, I know I've alluded to this a few times, so now we'll go into it in more detail. So when we identify somebody that we suspect has a genetic heart condition, again, let's use cardiomyopathy as an example. We know that with a lot of these genetic heart conditions that closely related family members, so that's parents and siblings and future children, are also at risk to develop heart conditions over their lifetime. But sometimes it's not always clear who is at risk. With many of these different heart conditions, actually, we can see a lot of variability in a family of the severity of the condition or the onset of the condition, with some people presenting much earlier in life and other people presenting much later, and sometimes in that case at a point where it's a little bit too late in terms of really being able to significantly do something with management. So being able to identify these individuals in the family early is really important for being able to proactively manage and watch their hearts. So when we see a patient that has one of these suspected conditions and we do genetic testing and it comes back positive, that allows us to test these closely related family members to further determine who exactly we think is at risk for developing that specific genetic heart condition as well. And then that also can help us determine who maybe isn't at risk and who might not need to be followed as closely moving forward. So again, really helping us to care for the entire family as a whole, and making sure that everybody gets the appropriate care and follow-up. So in the instance of cardiomyopathy, again, to use this as an example, those who test positive for one of these genetic conditions, we know, that they should have ongoing cardiac screening and closely follow with a cardiologist. But when somebody tests negative for the specific genetic heart condition in the family, that lowers our level of suspicion that that individual is at risk to develop that heart condition. And so they don't need to have their hearts looked at as frequently as somebody that has a known genetic heart problem. All right, Aisha, I'll pass it to you.
Thank you, Hannah. So as you heard from Hannah, genetic testing can really be helpful in with cardiomyopathy, but it can also be very helpful, of course, with the other conditions. So talking a little bit about how it can affect individuals who may have an aortic issue or might be suspected to have an aortic issue, genetic testing is very helpful as well. So oftentimes in our clinic, we'll have individuals who are referred to our clinic because they have some physical features of a connective tissue disorder that can affect different parts of the body, as well as the aorta. So when we look at the aorta with an ultrasound, they may already have an enlarged aorta, which is further, proof that the child might have this condition. Or they may not. And we know that issues that affect the aorta can emerge over time. So a genetic diagnosis can be really helpful to understand whether or not a child might have that connective tissue disorder, even if their aorta looks normal at that first point that we look at it. It's also helpful to know, well, is the child likely to need any specific types of heart medications or surgery in the future? We know that different genes that cause aortic problems can also cause risk to other blood vessels, and they might be at risk of tearing and rupturing like the aorta. So in that case, we might need to image other parts of the body, like the brain or the abdomen. Genetic testing can also help to determine, well, what other parts of the body are likely to get affected and which other specialists should the child see. And then finally, if the aorta is enlarged, at what point might surgery be necessary? We know that if the aorta is enlarged, it is weakened, so it can be at risk of tearing or rupturing. And this is really an emergency situation that we want to avoid at all costs. So what is often done for individuals with these conditions that affect the aorta is a surgery. And the surgery is done before the aorta gets to a certain size or a certain diameter. We know that with certain genes that surgery needs to happen at a smaller diameter, because we know that those particular genetic conditions can cause the aorta to be even more fragile and rupture at smaller sizes or smaller diameters. So genetic testing is not only helpful in diagnosing, but really treating and managing the recommendations that we make for individuals with these aortic conditions. Next slide. So what is it like to meet with a genetic counselor? Well, we take a deep dive into the relevant medical history before we see a patient. During the time that we're meeting with a patient, we'll also be collecting the family history. We'll talk about the genetics and educate about kind of the different genes that might cause the particular heart condition that the individual is suspected to have, or that they may have. We'll talk about, well, what are the genetic testing options that would be most appropriate in those cases, well, what types of results we can get, and which other family members need to be evaluated. And then we also help to put individuals in touch with some research opportunities. Next slide. So when should you see a genetic counselor? Well, oftentimes it's when a child is already known to have a heart condition that seems to be genetic because there's no truly defined cause that's attributed to the environment. So the types of heart conditions that we see are the ones that we mentioned previously: congenital or heart disease, high cholesterol, dilated aorta, as well as conditions that affect the heart rhythm or the heart muscle. We also can help with diagnosis. So even if a child is not known to have any of these heart conditions, but is suspected to have one of them based on either symptoms or physical features that might be observed, then a genetic counseling visit might be very appropriate as well. And finally, a child might actually have a family member with one of these conditions, and we may or may not know the genetic cause of the family member's heart condition, but a genetic counseling visit can help impact the care of that individual, as well as the rest of the family in that case as well. So as Hannah mentioned, we have multiple different teams at Stanford that take care of individuals with inherited and genetic heart conditions. And we as genetic counselors tend to work very closely with those teams. And that team might include primarily the cardiologist, the physician assistant, maybe the nurse practitioner, certain nurses and members of the scheduling team. But in some cases, it extends beyond that. So I want to just spend just a quick minute telling you about our connective tissue disorder clinic that is multidisciplinary. So in addition to having the cardiologist and the geneticist, we also have many different specialists that help to take care of our patients. And the reason for this type of care model existing is that we know that individuals who have issues with the aorta also very often have differences in other parts of the body that need specialist care. So this is, a very important way to be able to provide good care to our patients, where in the same day they will often be able to see all the specialists that they need to see. The specialists will talk to each other to come up with a cohesive plan and be able to best care for the patient that way. This is one of our clinic is one of the largest connective tissue disorders clinic in the country. So with that, I hope that you learned that genetics plays an important role in cardiovascular issues. Genetic testing can be really helpful for diagnosis and to know what to expect in the future. And it can also help other family members as well. So thank you so much for listening. We're very happy to take any questions that you might send our way.
Thank you, Aiste and Hannah, for that great presentation and sharing all of that really critical information. So as we've been saying, we are going to open it up for questions. So just as a reminder, be sure to type your questions into the question box in your control panel. But we thought we'd actually get started with some of the questions that Aiste and Hannah get most often from patients and from their families. And so I'm going to start us off with a very basic question. So can you both talk about how common are inherited cardiovascular diseases? What are the chances that any child would have one of these diseases? And maybe a connected question is, if a child's parent has one of these diseases, what are the chances that that child will also have a similar disease?
Thank you. That's a really great question. And the chance that a child might be born with a particular heart condition or develop a particular heart condition over the course of their life really varies based on the type of heart condition that we are talking about. So I'll kind of review the most common types of genetic heart conditions so that you can get a bit of a sense. So one of the most common ones is a congenital heart disease, so kind of a structural difference in the heart that the child is born with. And this occurs in about 1 in 100 or about 1% of babies who are born. The next kind of more common one is a condition that affects how cholesterol is made and processed in the body. And the most common kind of genetic condition that causes that, it occurs in about 1 in 200 individuals. Conditions that affect the heart muscle, the one that causes the heart muscle to be thick occurs in about 1 to 500 individuals. And the one that causes the heart muscle to be thin is about 1 in 250. And then I can't leave out the most common aortic issue, which is that of Marfan syndrome. And this occurs in about 1 in 5,000 individuals.
Okay.
And I think the second part of your question, Casey, is, well, how likely is it that it's inherited, or how likely?
Yeah, so if a parent has a cardiovascular disease, how likely is it that their child will then have the disease?
Yeah, most of these conditions, as Hannah mentioned, are inherited in this dominant fashion. So that means that to have this condition, the parent needs to have a change in one of the 2 copies of the gene that they carry. So when they go on to have kids, they can pass on either copy, which means that the child has a 50% chance of inheriting that non-working copy of the gene and then having the condition, or inheriting the working copy of the gene and not having the condition.
Okay, great. I think another question that's probably burning in people's minds is, you mentioned there are so many genes in the genome. And so do we have a feel yet for how many might lead to a cardiovascular disease when mutated? So, when you're doing a genetic test, you're talking about these panels. How many genes are on these panels? How many do we know are involved? Maybe that's a better way to phrase the question.
Yeah, I think that the size of the panel certainly will vary based off of the genetic condition. So for instance, for some of these inherited cholesterol conditions, my panel might only have anywhere between like 4 to 8 genes on it. But when I'm seeing a patient with congenital heart disease and we order a panel, that tends to be a panel that has at least over 200 genes on it, sometimes closer to 300. So I think it can really vary depending on the indication that we're seeing. And then the larger that it is, the more likely you are to potentially get some of those uncertain results back. So just something we tend to talk often about with our patients is the more that we're looking, the more likely we might be to find something that we're not quite sure what to do with, but that we might be able to do something about later on.
Mm-hmm, mm-hmm. Okay, great. And so we have a couple of questions from the audience. And so first question, is there any type of congenital heart defect that you wouldn't do genetic testing if a patient presented with this defect?
Yeah, that's an interesting question. So I think the guidelines say that, when a child is born with congenital heart disease, that at the very least, a chromosomal microarray should be considered. So I would say that tends to be sort of the guidance that we think about, which is, any child born with congenital heart disease, even if it's seemingly isolated, should probably have a chromosomal microarray performed. And I think that, consideration for other testing could also be considered as well, depending on the patient and the type of lesion that they have.
Mm-hmm. Okay, cool. Another question from the audience. If a child has a known anomalous coronary artery, does that child need a referral for genetic testing? And is that something that a cardiologist would order? So could you maybe walk us through how getting to the point of genetic testing might work for that patient?
Yeah, so I think that It varies. I think the way that a lot of our teams work is that a lot of physicians have a genetic counselor that they work closely with. And so if a doctor or cardiologist sees a patient that they think would benefit from genetic testing, they'll refer to us, or we can see them alongside that physician in a team style clinic. And then, so I think that oftentimes that referral to genetic counseling will come from a cardiologist asking us, but I do think there are some cardiologists that might feel comfortable ordering their own genetic testing. I just know here with our teams, oftentimes, we're the genetic counselors are sort of the primary people assisting with actually doing the genetic testing and assisting with the kind of logistics behind that. So we've talked a little bit about anomalous coronary artery, and I think that our understanding of the genetics of that in terms of that being an isolated finding is not as well understood, and the yield is probably pretty low in terms, and when I say yield, I mean the chance we'll find something on genetic testing tends to be a lot lower with that. So I don't know that, if that was the only thing that child had, or that was the only, difference that child had, I don't know that genetic testing would necessarily be super fruitful.
Okay, great. Next question. My son was born with hypoplastic left heart syndrome, diagnosed postnatally. Is there a high risk of having another child with the same condition?
Yeah, that's a great question. So their hypoplastic left heart sits within a category that we call left ventricular outflow tract obstruction defects. It's a very long word. We'll call it LVOTO. And we know that certain types of types of congenital heart disease that fall within that spectrum, the LVOTO category, actually we think of as being much more heritable than other types of congenital heart disease. So, without knowing the specific underlying genetic cause of a child's genetic heart condition, we can't give oftentimes a specific recurrence risk number to a future child. But we do know that risk in individuals that have a baby with hypoplastic left heart, or something such as another type of heart defect that lies in that spectrum is coarctation of the aorta or bicuspid aortic valve. We know that individuals that they themselves have that type of congenital heart disease, or have a child with that type of congenital heart disease, that their risk to have another child with congenital heart disease is greater.
Okay.
And so what I will say is that certainly any future pregnancies, and this goes for any congenital heart disease, we recommend a fetal echocardiogram for all future pregnancies, and echocardiograms for all first-degree family members of somebody that has a left-sided heart defect.
Can you expand on that a little bit? How often do you have a patient, a small child, for example, present with a heart defect, and they're doing genetic counseling? How often do you then find something in a parent or a sibling that maybe wasn't noticed before? Because we're talking about how it runs in family, and there's perhaps an increased risk. Does that happen very often?
Yeah, so anecdotally, just in terms of my personal experiences, that hasn't happened too much, but things in terms of like getting somebody's family member an echocardiogram and making sure that they follow through with actually having that done, I just don't hear about those things as much. But I do know, what I can say is that we do know that when somebody has one of these types of heart diseases that fall on that spectrum, that the data suggests that up to 20% of those individuals will have another first-degree family member or closely related family member that also has congenital heart disease. And some of those types of congenital heart disease can be more mild, where somebody might not actually know that they have it. So bicuspid aortic valve is one of those particular conditions. And so that's why we recommend that when somebody has one of these left-sided heart diseases, that their closely related family members have their hearts looked at to screen to see if they might have a more mild type of difference, like bicuspid aortic valve, that could have downstream impacts on health later on in life.
Okay. And you mentioned bicuspid aortic valve. being a related left-sided defect. My understanding is that's far more common, actually, compared to some of the other defects. Do you want to talk a little bit about that as well, and what we know or don't know about the genetics of that defect?
So I believe, and I say, do you want to go for it? Because I feel like you work with bicuspid aortic valve a lot as well. I'm happy to. Oh, is your...
Oh, sorry, I was just trying to unmute myself. So this is definitely one of the most common types of congenital heart disease. And we do know a few genes that can cause the valve to have 2 cusps instead of the normal 3 cusps, but too few to actually do genetic testing for it routinely, unless there is something else about the child that suggests to us that they might have kind of one of the connective tissue disorders that can also cause the aortic valve to be bicuspid. So it is very common, but as a general rule, we know that if we do genetic testing, we know so little about the genes that cause it that we're not very likely to find anything. But we do very often do genetic testing for a suspected connective tissue disorder, of which bicuspid aortic valve might very well be part of.
Okay. So I think we have run out of time. We have covered a lot of ground today. I want to thank Hannah and Aiste for giving us a great presentation and spending some time with us to talk about the genetics of cardiovascular diseases. Thanks again to our audience for joining us today. And we hope to see you next time for part 2 in our 3-part cardiogenetics series. In the second event, we'll actually cover some of the research efforts underway at Stanford School of Medicine and the Betty Irene Moore Children's Heart Center that are aimed at really improving our ability to predict, diagnose, and treat some of the diseases that we've been talking about today. You'll also get a tour of a research lab and get to look firsthand at some of the ongoing experiments that we're doing to really get at the cause of this really awful disease. So we hope you tune in, and we also hope that you enjoy the rest of your week. Bye.